Good morning, everyone, and welcome to our session today titled Innovative Practices to Addressing Hypertension and Diabetes with a Health Equity Lens. My name is Rima Naik, and I am a program manager at Nevada Primary Care Association. Nevada Primary Care Association helps community health centers provide exceptional medical, dental, and behavioral health care to Nevadans by advocating for policy changes, providing training and technical assistance, and creating economies of scale through program management. For more information regarding our PCA or to subscribe to our wonderful newsletter, you can visit us at nvpca.org. This presentation that we have today is in partnership between Nevada Primary Care Association and the American Heart Association. I just want to take a quick moment to thank them for helping us coordinate this training. And before we begin, we would like to go over some logistics and housekeeping items for today's session. Please, in the chat box, type in your name and your title and your organization that you're coming from today. It is really nice to see who from the community is attending. During the presentation, please mute your phone or computer so we don't have any feedback or background noise. Also, please do not put your phone on hold or we'll hear your hold music. You'll have the opportunity to submit any questions to the presenters by typing in your questions in the chat box at any time. We will actually have time in between the presentations to go over the questions that you may have for each presenter. We're also going to have an evaluation at the end of today's session. Please take a couple of minutes to review and give us feedback so we can continue to provide high quality trainings for you and your teams. I'm now going to turn over our presentation with introducing our speakers, starting with David Brewer, who is the Director of Clinical Services and Quality Improvement at the Heart of Ohio Family Health in Columbus, Ohio. David, I'll pass the baton to you.
I'm David Brewer. I'm the Director of Clinical Services and Quality Improvement at Heart of Ohio Family Health. At Heart of Ohio Family Health, our mission is to provide high quality, holistic, and compassionate care to meet the healthcare needs of everyone in the diverse community, one heart at a time. We have 5 different clinic locations, and we are located in Columbus, Ohio, which, believe it or not, is more than just cornfields. Not sure what everybody in Nevada may feel about Ohio or what they've heard, but we are the 14th largest city in the US. And all of our clinics, you can see our 5 clinics here with the hearts, are located on the east side of the city. We are 134 employees, 30 providers, which is a combination of different providers, and we'll get into depth of the different providers that we have on, and you can see the makeup of our board. And approximately a third of our staff are bilingual or multilingual. To give you a little bit more context about our organization, we served about 14,000 patients in 2021. Our makeup of our patients, you can see starting on the left side of the screen by race, over 50% of our patients are Black or African American, 21% are white, and about 10% are Asian. And 15% of our patients are Hispanic. And then shifting over to the right side of the picture here, as far as languages, we have a very diverse, linguistically diverse patient base as well, with about a third of our patients speaking a language other than English. And note, I said before that about a third of our staff also speak a language other than English. So we try to have a staff that's reflective of our patients. And of those non-English speakers, Spanish is the largest language at about 12%, Nepali at about 8%, and Nepali at about 6.5%. And then Amharic is spoken, and Tigrinya those are primarily spoken in Ethiopia. And you can see we have more females than males in our patient population. Giving a little bit more background too, we are a quickly growing company. You can see our patient base, the total number of patients grew by about 25%. Our visits grew about 28%, which is significantly faster than the national average. Our diabetes control ended the year at 19%, which is one of the better control rates in Ohio. Our hypertension control rate at 74%, showing improvement year over year. And then you can also see the growth in our providers and staff. So I give you, and then you can see nationally for UDS in the bottom right in that orange square, diabetes control rates on average are about 35% across the country, and hypertension control rates at 57%. So we're doing pretty well in those two areas. So that was all to give you some context. We also have been recognized in a few ways. We won the Health Center Quality Leader Award from HRSA. We are Gold Plus certified American Medical Association, American Heart Association for hypertension control as a part of their Target BP program. And we've won a couple of other awards as well from HRSA. One that I want to highlight for the purpose of this presentation is the Health Disparities Reducer. So we'll be talking a little bit about how we did that for diabetes and hypertension. So sharing how we got here, this is our path. You see back in 2018, we have a very poor control of hypertension in our clinic at about 52%. I started in 2019 and immediately recognized this as an area of need. And you can see every year our hypertension control got significantly better. And you can also see that our patient population for hypertension grew significantly each year as well. So, and then for diabetes, you see much of the same. We had a little bit worse of a year for diabetes control in 2020. The pandemic made it a lot harder to get A1Cs, and that was a big part of that. And you can see that we were able to make big strides in our population as a whole. And moving on and digging into those control rates from the perspective of health disparities, you can see here for all of our patients for hypertension, that control rate was 74%. And that also happened to be the hypertension control rate of our white patients. And we calculated what we call a disparity ratio and what that means is if the ratio is greater than 1, it's a comparison of the patients compared to the white patients in our practice and seeing if there's a disparity between the other race and ethnicity groups versus our white patients. I have not seen this used in the past before as like a benchmarking tool for diabetes and hypertension, but it's commonly used for things like infant mortality. So I thought it would be useful to apply here. And you can see for Black and African American patients, we were slightly worse in hypertension control compared to our white patients, but you can see on the right side, the benchmark where it says benchmark disparity ratio, we found some benchmarks through the American Heart Association showing that in the country as a whole in the US, the disparity ratio is a lot worse. So that gives us, something to compare. How are we doing compared to everywhere else? And then for diabetes, you can see too, it says diabetes QIP clinic. So we participate in a quality improvement project. That's what QIP means, with about 15 other practices in the Ohio area. And although we weren't able to find any national data to benchmark disparities, we used some data from that project from those other clinics, and then we were able to compare it to our own. So the lower the disparity ratio, the better. And you can see that we've managed to do a great job in reducing that disparity for hypertension. For diabetes, we are doing better than the benchmark numbers, but still room for improvement. And over the course of this project, we also looked at the systolic and diastolic blood pressure over time, just to see, as we went about some of the improvement efforts that we talked about, that I'm going to talk about in a little bit, did those improvement efforts lead to improvements in all of the race and ethnicity groups? And for systolic and diastolic blood pressure, we saw all races improve throughout this project. So we'll be sharing a little bit more about how we did this. So this is the diastolic. So you can see all of the different lines are showing some improvement. So some of the different frameworks that we used as we went about trying to make improvements in health disparities for diabetes and hypertension were, looking at the different aspects, the people, the process, and the technology, and then applying the PDSA Plan, Do, Study, Act cycle. Of course, to make improvements like we did over this time frame, it's more than one thing. It's dozens of efforts, and I've written out a lot of them on here and then highlighted a few that we're going to go over. So I'm not going to go through each and every intervention on here, but we're going to go through some of the highlighted ones. So equity, this was on our minds about as we were making these improvement efforts, is how do we provide equitable care? And there's this neat graphic that shows what equity really is versus equality that I think is always good sharing when you're talking about equity. So one of the key components of our plan was to build an integrated care team. And then to have clear defined roles for each of them. So we have our dietitian, roles being nutrition education, behavior change counseling, our clinical pharmacist who doesn't dispense medication, but adjusts medication under a collaborative practice agreement for diabetes and hypertension. And then we found that our pharmacists have been invaluable in advising our providers, helping to create protocols, starting special programs like continuous glucose monitoring and remote patient monitoring. And then we have an RN care coordinator whose role is more of the general disease state education, medication adherence and administration teaching, outreach to patients that have uncontrolled diabetes who haven't filled their medications. We get some of that data from our 340B program of patients that aren't filling their medication and from our EHR. And then they do a lot of remote patient monitoring for primarily for blood pressure, but a little bit for blood glucose as well. And we have community health workers that assist patients with social determinants of health, connect patients to home blood pressure monitors because the insurance companies don't make it simple by covering it at the pharmacy. So we have to have special resource to help patients navigate and providers navigate how to get people blood pressure monitors, as well as get people who can't afford a blood pressure monitor. They coach patients on a produce prescription program that we have that I'll talk a little bit more about, and do outreach calls to prevent patients being lost to care, which I put it last on the list, but really this is a huge part of what we do is those outreach calls to get people back in, because I think most places, if they did an analysis of their numbers, they would realize that people aren't getting better because they aren't coming in for visits. And then we have our behavioral health team, a counselor and a psych nurse practitioner to manage the different behavioral health needs.
Hey, David, while you're on the previous slide, because one question that came in, are you able to bill for the RN care coordinator?
We bill the in-office visits as nurse visits. Our RN care coordinator, we are able to bill for remote patient monitoring as well, that the RN does under supervision of the provider. We are not able to bill for phone visits or home visits that this RN does.
Thank you.
Mm-hmm. Then we have some standardized referral processes that we strongly encourage our providers to follow. And I'm not going to go through every single step on here, but a big piece of this is defining the different situations when a provider may want to refer a patient to a pharmacist, a dietitian, or an RN care coordinator. And a big piece of it is assessing if the patient is adherent with medications or not, if they have a high A1C, if the patient is adherent to their meds and taking their blood glucose at home, then it takes this route where the patient gets referred to our pharmacist or the provider and the dietitian. Or alternatively, if the patient is not adhering to their meds, the first route we take is referral to the RN and the dietitian. So the difference there being adherent patients, we need to optimize your med regimen. We refer those to the pharmacist. Patients that aren't adhering to their meds, they need more of that case management coaching that the RN care coordinator provides. So that's kind of how we split up these protocols. So I'm sure you'll be able to review the video and get the details of this, but we did the same exact thing with hypertension, where patients that are adherent to their meds and taking their blood pressure at home consistently, those are referred to the pharmacist. If they are not doing that, then the first step would be to send them to the RN care coordinator, where we would get them taking their meds consistently and taking their blood pressure at home consistently. And then if they're still uncontrolled, then we get them to the pharmacist. So, and then another step that we took on the, as far as provider protocols, was standardizing the prescribing habits and also holding the providers, quote unquote, accountable, or providing them with the information about what their habits are compared to others in the practice. So we did a project where our pharmacists did a training of all providers on the preferred second line diabetes treatment options. And those are the SGLT2 and GLP-1 medications as the primary choice after metformin in most cases. And they provided training on that, as well as some special situations like low income patients. How do we get them these medications at a discount? And we shared provider level data with our providers as a reminder, mainly that serving as a reminder for, hey, we're paying attention to this. We gave you this training and we want you to see how you're progressing compared to others in our practice. And you can see that we had, before we did the intervention, about 14% of our prescriptions for diabetes medication were for these SGLT2 and GLP-1 medications, whereas in the 3 months after the intervention, we were able to increase the total diabetes prescriptions by about 5%, total prescriptions for these two medications as a whole, compared to all diabetes prescriptions. So for hypertension, we did something a little bit different. We have a treatment algorithm where, depending on the patient's blood pressure stage and their race and whether they have diabetes, albuminuria, or CKD, what medications should be chosen and how to titrate up and all of that. So providers are all given a training on this when they start by our pharmacists. Although we don't have that precise data that we had for diabetes for hypertension yet, anecdotally training the providers on that, giving them that algorithm, we've seen some improvement. And what we want to begin to do is next steps is to break down the algorithm and see, what things could we research? Are we prescribing the appropriate drug classes for African American patients according to our algorithm? Are we prescribing the correct medication, such as there have been a lot of suggestions that chlorthalidone may be preferred over hydrochlorothiazide, especially for African American patients. And then for patients with that significantly elevated blood pressure, are we initiating two medications? So those are some of the things that we're hoping to research in the future and be able to give our providers some data about how they're prescribing. Another big component about how we went about improving our blood pressures was retraining all of our providers and MAs on appropriate blood pressure measurement and rearranging our exam rooms. For example, some of our exam rooms have wall-mounted blood pressure units, and based on the placement of that unit, it may encourage the MA or provider to put the patient on the exam table where their feet are not flat on the floor, not back supported, that sort of thing. So we rearranged our exam rooms, bought some new blood pressure monitors, and implemented a retake protocol and for all blood pressures over 140/90. And then we began to measure it and share those measurements with our providers. So you can see a graph here on the slide of the percentage of patients that we were retaking blood pressures for and how we were able to make improvements. And we communicate this constantly and show our staff the data. Another program that we piloted was remote patient monitoring for hypertension. And here is some of that data that came out of our initial, it's about a 9-month period from December of 2020 to August 2021, where we did an average. We did of the first 4 readings that the patient got when they were doing remote patient monitoring versus the last 4 readings that the patient got. You can see there was significant improvement here in the graph on the bottom left of patients that had the last 4 readings as more controlled and also having fewer uncontrolled patients, as well as having the average blood pressures drop from the before and after as well. So we think RPM is very, very promising in making a difference for our patients. Another thing that we did was a standardized follow-up protocol. So giving 1-month follow-ups or sooner for all patients with uncontrolled diabetes or hypertension, with a pharmacist, a physician, or a nurse practitioner, somebody that could prescribe and send medications out. We chose a threshold of A1C greater than 8 because what we realized when we looked at the data was all of our patients with an A1C of 8% to 8.9%, more than 40% of them were progressing to an A1C greater than 9%. So we thought that addressing them a little bit more aggressively to prevent that progression would make a difference. Here's an example of some of the steps and the improvement that we saw with getting patients scheduled for a follow-up according to that protocol. A 1-month follow-up. Originally, it started as A1Cs greater than 9. So you can see, in November of 2020, the providers were given that protocol to schedule a 2 to 4 week follow-up with a prescriber. January, we provided providers a scorecard every month, starting in January of 2021 of what percentage that particular provider was scheduling with a 1-month follow-up. But we started it quarterly, and then by April, we decided we need to be sending this to our providers every month. And then we did some huddles to encourage our MAs to also be looking out for this. We changed our protocol to be A1Cs greater than 8 have a 1-month follow-up. And in October of 2021, after a ton of communication, repeating this over and over and sending the providers their data, providers that had still had performance significantly below the average, we put them on improvement plans. And we really approach these in as non-confrontational a way as possible and telling the providers that we're here to support you. These are your numbers. What can we do to help you help your patients? And you can see the graph on here of how we saw improvements over time. Here's an example of the scorecards that I mentioned that our providers get. It has a lot of the data that I just mentioned. And I think that this was a really key part of our success is if you don't have data, you can't know how you're doing, and you need to be measuring the processes, not just the outcome. So measure the process to get to your goal and communicate it until you're sick of saying it. I also mentioned that we have community health workers and that we did some work around addressing social determinants of health. We screen all of our patients for social determinants of health needs. We have a program called the Mid-Ohio Pharmacy Program, where patients get free fruits and vegetables once a week, no appointment needed, at over a dozen locations, dozen different food pantries in the Columbus area. And we have over 2,500 patients referred to that. We've also had over 2,000 referrals to our community health workers as a result of screening our patients, and then our community health workers connect those patients to what they need. And then I mentioned this briefly at the beginning, we have a community health worker dedicated to preventing these uncontrolled loss to care, assisting them with things like getting a home blood pressure monitor. And one of the considerations that we made when we created this position was that we had a disparity in our Hispanic patient population, most of which here are Spanish speakers. And we hired a Hispanic and Spanish speaking community health worker to do these outreach calls with the hope that we would see greater improvements in that particular group. And we've had some success with that. If you remember on my very first slide, or one of my first slides about the disparity ratios, there was very little disparity for our Hispanic patients for hypertension. Another thing that we did was addressing medication adherence. We pulled reports from our 340B contract pharmacies and identified patients that didn't fill their prescription for diabetes and hypertension meds. And then our RN care coordinator calls those patients and assesses the situation and helps the patient navigate or give education, whatever that patient needs to become adherent. So just, we've learned a lot in this process. We've made a lot of progress and feel good about what we've done, but we feel like we're still learning every day. We think that the team-based approach, interventions tailored to individual patient and group needs that have disproportionately worse health are important. So screening all of our patients for community health worker intervention, we think that that disproportionately helps our patients and promotes equity, along with our food insecurity intervention of the pharmacy program. We think a lot of these interventions promote equity. And then, tracking and communicating data constantly to staff was another big key to our success. And one of our next steps, which we have just very, very recently achieved, was being able to measure our outcomes on a more timely basis specific to race, ethnicity, and language, and then tailoring interventions to decrease those disparities. So we've been able to get a lot of looking back data, but now we're able to get that data a lot more timely for race, ethnicity, and language. And we've begun to tailor some interventions for hypertension, diabetes, as well as other things. Does anybody have any questions for me?
Looks like we had some questions in the chat box, and then we can open up the floor to everyone who is here. So going back to a couple of your slides and information, the first question is, what is your reaction to the benchmark on the HRSA website for diabetes poor control set as 11%?
I think that we will reach close to that in the next 2 years. I think it is it is an extremely ambitious goal. And as you can tell, we have put a lot of energy and effort into improving these, and we are still, I think we'll be a lot closer. We'll probably end this year around the 15% control mark. I think that 11% is very ambitious, but possible for some clinics.
Thank you. Another question that we had on hypertension was, how do you help your patients get them a blood pressure monitor?
Our community health worker is able to, depending on the patient insurance, our Medicaid in Ohio, most of the plans require that the patient have the prescription sent to a durable medical equipment company. So the different companies have different forms that they require to be filled out. So the provider puts in the order for it, and then the community health worker will, for those Medicaid patients, fill out the form, send it to the appropriate durable medical equipment company. A lot of our providers, before we did this, would try to send them to the pharmacy where they would be denied, and the patient would either not get it or pay out of pocket. Another way that she helps patients is for a lot of privately insured patients. It's ambiguous whether their insurance covers it, whether it should go to a DME or a pharmacy. So she helps call the insurance and navigate that situation. And then for our uninsured patients, she schedules them with we have something here called the charitable pharmacy, where they can give medications or glucometers, blood pressure monitors to patients for free. So that's how she helps the uninsured patients. And based on the patient insurance coverage as well, she would talk to them about our remote patient monitoring program and get them set up with one of our devices.
Thank you, David. And we want to open it up to the floor now. If you would like to unmute yourself to ask a question to David or put it in the chat box, feel free to do that.
This is Mary. One of the questions that has been running through my mind of late, and I actually posed it to one of our clinicians this morning, is it'd be interesting to me if we had the resources to do a study on the patient outcomes related to that multidisciplinary team. You know, what was the patient outcome when they had the clinical pharmacist and PCP and the CHW and the behavioral health, all following up with the patient on patient education. We don't have the RN care coordinator. And then try and measure those outcomes broken down by, did this person have 4 wraparound support providers? Did they have 3? Did they have 2? Did they have 1? Did they refuse any of them? Just to try and get a sense of, is one of those multidisciplinary team providers having a greater impact on patient health outcomes? I don't know whether you guys have talked about that or not. You're much further along than we are.
The data analysis for something like that is quite advanced, and with resources stretched thin over the pandemic years, we have not been able to study that to the degree that we would like. It's been on our radar, but no, we have not. I can say from a previous role, I've done pretty extensive look at the dietitian's impact. Not looking at the full interdisciplinary team, and there is a significant impact, but I can't speak to exactly what you said.
Thank you. Great work.
Thank you.
Seems like there's not a crowd. I'll ask my question. David, that was wonderful. Thank you so much. You guys are very inspirational. I think we feel like we're at the very beginning of what you have accomplished. One question I had was for the monthly reports that you were providing to the providers. Did you have to come in with your own overlay over your EMR, or were you able to pull that out of your, I'm just sort of curious about what your ultimate strategy was with that. We're also limited by our EHR, and there's all these companies out there that want to sell for a very high fee their additional services to lay on top of your EHR and provide some of these consolidated reports, which would be super helpful. So I'm just curious about how you finally got there, because you talked about that being a long process.
We took an interesting route to accomplishing that. Instead of hiring an in-house data analyst, we hired, so the company we work with is called Unity Population Health Management. Highly recommend them if anybody wants to talk more about it. But we met them in their very early startup phase. We were their first client, and we really built the program together. That a lot of, I've used other systems like this, and a lot of them are cookie cutter, build this report, but their team is, they're computer programmers, so they can adjust the code and get you exactly what you want. And it's all custom built. And it would have been very hard to do without somebody with programming knowledge and data analytic background on the team, which they have both.
That was my guess. Very complex solution to something that would be just super valuable to have.
Yeah.
Any additional questions for David? Okay. Well, if there are any additional questions, you can always email them to us, and then we can reach back out to David to see if he can address them. But with that being shared, we wanted to pass it along to our next presenter, who's joining us from San Diego. We have Dr. Melissa Bishop, who is joining us from Neighborhood Health in San Diego, and she's the medical director of quality. So that's share, Melissa. I'll pass the baton to you.
Hi, thanks, Rima. Let me see if I can pull up my slides. All right, are you seeing my screen?
Yeah, we see the PowerPoint.
Okay, great. Okay, super. Can you see that?
Yes. Yep.
All right. Okay, all right. Well, thank you so much. I'm excited to be here and to share what we've been doing at Neighborhood around team-based care and chronic disease management. I wanted to describe what we did, a pilot we've been running over the last year to address our patients' needs who have chronic disease using team-based care and virtual technology. So learning objectives, this is from a previous presentation, but with the things that we'll touch on are to become familiar with the use of data to drive quality improvement, understanding the use of the multidisciplinary healthcare team and managing chronic disease, and using technology to accelerate and amplify new models of care. Neighborhood healthcare, a little about us. We are an FQHC based in Escondido, California. We serve San Diego and Riverside counties. We have 17 sites, almost 100 FTE medical and behavioral health providers. We serve about 78,000 patients per year. And the pilot, the virtual care team pilot, the key components to our pilot were the team plus data plus technology. So regarding the team at Neighborhood, we began developing primary care teams about 10 years ago. The core team consists of a PCP, 2 medical assistants, an RN case manager, and behavioral health consultant are shared between several teams. Within the team, the medical assistant is responsible for addressing the chronic care needs that the patient has, any preventative care needs. We have a special app that we've built on, you'll probably be interested in this. Our EHR is not as functional as we like. We have a medical director of informatics who's a physician that also has programming skills, and he built an app to run alongside our EHR that allows information to be presented and actionable very easily at the point of care. So this allows the team to notice care gaps very easily and close those it's easy to enter orders. Medical assistants do it by protocol. So we also have a long history of using data to drive our improvement efforts. I'm going to be sharing some examples of the reports that we use. What we noticed with COVID was that many of our quality metrics really deteriorated, especially around diabetes and hypertension control, and this brought new urgency to our quality improvement work. It also brought new opportunity because we now had telehealth available and remote patient monitoring. So in early 2021, we began to design this new type of care team to target the needs of our patients with chronic disease. So the virtual care team would be an internal referral resource of a team specially trained to provide protocol-based care for new onset diabetes, hypertension, and nicotine cessation. And using virtual technology, we could use a single centralized team to provide services to patients throughout the large geographic area that we serve. So for background, cardiovascular disease is the leading cause of death in the United States. And compared to the general population, health center patients, have much higher rates of hypertension, diabetes, hyperlipidemia, and overall poor health. And I'm sure you all are also aware that to take care of chronic disease well is very time consuming. And you can see that in these diagrams where the American College of Cardiology, the American Diabetes Association are describing what optimal care of diabetes and hypertension would look like. And most of our patients have both of these problems in addition to other chronic diseases that have their own guidelines for best practices. So to do the right thing is very time consuming. However, in primary care, we actually don't have very much time. Patients are booked every 15 minutes. We're booked out for months. And in 2009, this study in this public health journal estimated that it would take 27 hours a day to provide all the necessary preventative and chronic and acute care services needed for a patient panel. So it's just not mathematically possible for one individual PCP to address all of their patients' needs. And because of that, we wind up, we have a primary care system in which we know what the right thing to do is, but there's not enough time to do it. Every primary care provider has to choose and select which services they will offer their patients since they can't provide everything. And that results in a lot of variability in performance. So you can see here within our organization, rates of diabetes control range from 82 to 50% by provider. And that variability can also lead to disparities. So here are our quality metrics broken down by race and ethnicity. And you can see the variation here that our non-Hispanic white patients are more likely to have their diabetes and hypertension controlled in comparison with our Latino and African American patients. So as FQHCs, it's our job to promote health equities. And in this project, we propose that team-based care is a way to use our finite resources to provide consistent and high quality care and reduce disparities. The foundation of team-based care is the team. So this definition from the National Academies of Medicine describes a team as a group of individuals who coordinate their actions for common purpose, which in healthcare is the prevention or treatment of disease and the promotion of health. Patients are actively engaged and everyone's functioning at the top of their license. There's a large evidence base for using interdisciplinary teams to manage chronic disease. So system-level disease management programs like were implemented at Kaiser or protocolized treatment by nurses and pharmacists have led to improved care in patients with hypertension and diabetes. For our patient population, we were specifically interested in focusing on patients with newly diagnosed diabetes because there's abundant evidence that early aggressive treatment of new onset diabetes improves long-term health outcomes. This is called the legacy effect. And when patients are newly diagnosed with diabetes, they're just kind of ripe for education and intervention. It's just a time of life where change efforts are most likely to take root. And we thought intervening with this patient population could be especially impactful. So this is our team for the virtual care team. It's 2 care coordinators, 1 nurse, 1 medical assistant, and 1 medical provider. And then as needed, we have access to a clinical pharmacist, behavioral health, social services coordinator, and folks at the sites to help us with face-to-face care. Our care coordinators are MA trained MA level employees who have had additional training in chronic disease management and motivational interviewing. So we prepared the team by sending our care coordinators for training as diabetic peer educators. Our internal CQI committee created treatment protocols for diabetes, hypertension, and nicotine cessation, just based on standard guidelines. From those, we created standing orders, which allows our nurse to make adjustments to diabetes medication. We created templates in the EHR to give scripting to the team members to help them with collecting HPI information. Our clinical pharmacists met with the team and discussed best prescribing practices and how to access affordable medication. And then our RN CDE trained the team in using continuous glucose monitors. Okay, so I wanted to just give some examples of the data. We're very fortunate with our data program. We have great access to real-time data. So I'll just show you a few pictures of what we have. I don't actually understand data that much. Like, I don't know what's going on behind the curtain, but I talked to one of our analysts. So I'll describe what he said, but I can't answer questions. I'll share his email address at the end. But the way he described it is our EHR is eClinicalWorks that I knew, but it uses a SQL database. We have a secondary copy of the database that is running all the time, and that's what we use to pull reports and pull data for that point of care decision app that I described. Because we can access our own data, we don't have to request things from our vendor. For our reports, we use Power BI, a Microsoft product. Our analytics team writes queries to pull the data from the SQL tables, and these can be scheduled to refresh automatically at designated intervals. So I'll go ahead and share some examples of what we've done with this. What I'm displaying right now is our organization-wide clinical quality dashboard. So what's displayed are the quality metrics that every year our clinical quality team meets and decides what we're going to prioritize for the coming year and what our targets should be for each of these quality metrics. So that's being displayed here. The bars are our current performance versus the dashed lines are our internally determined target. This is a really useful dashboard. We can drill down by facility, provider, insurance status, whether or not the patient has severe mental illness, race, ethnicity, and sex are all filters that are available to us. We can also drill down on each individual measure. We can also pull patient details and use these reports for outreach efforts. So this is, for example, this is drilling down on the hypertension measure. This is the trend line for hypertension. Trend lines are nice because it allows us to observe changes over time and the effects of our interventions. So this report is running from 2014 to 2020. Between 2014 and 2017, we participated in a countywide collaboration called Be There San Diego. The goal was to decrease the incidence of heart attack and stroke in our community. It consisted of sharing best practices, sharing data, and our performance in hypertension control increased from 62% and was sustained close to 80% until the pandemic when it dropped off. And then, as David mentioned, we also look at process measures because by focusing on the actual action that a team member needs to take to improve those quality outcomes, we can really kind of drive behavior. So this picture is depicting a process measure that we developed that we call InReach. And as opposed to outreach, InReach is measuring that when you have contact with a patient, when you're having a in-person or virtual visit, and you have the opportunity to close care gaps, how often is that occurring? So currently we have defined the InReach measure as including ordering an A1C when it's due, scheduling a repeat blood pressure check when it's high, ordering a FIT or scheduling a PAP when they're due, scheduling the retinal screen, and completing the SDOH and depression screening. So the team gets credit for taking action. Like they're not responsible for making sure that A1C is low. They just get credit for actually making sure it's measured. And then finally, I wanted to share a data dashboard because we build these to bring together related measures that we want to track over time. At the start of our virtual care team pilot, we thought ahead of time about what types of clinical and operational metrics we were going to want to keep an eye on, and how we would evaluate the program and decide if it was effective, if it was cost effective, if it would be worthy of further investment and spread. Okay, and for technology, we as I mentioned, have our own in-house tech support where we can build our own kind of tech solutions. And this was an early tech solution. This is the app that I mentioned. It runs alongside our EHR. It's pulling information from our EHR, and it's been designed to where we can present information that needs to be acted on. So in general, whoever you are, there are different displays depending on your role. So I, as a provider, will be presented with different information than a front desk person or an MA. But when I look at it and I see red, then I know that I need to take action. And then everything in blue, if I click on it, it's actionable. So if I see that my patient's blood pressure is high, if I click on that BP, I have the option to enter a referral for a home blood pressure monitor. If the A1C is high, I have the option to click on the A1C and order that, or refer a patient for diabetes prevention to our DPP program. And then, for example, on the statin, this patient, I'm being told that to consider treatment with a statin. If I click on that, then it opens up the screen to the right that shows how the cardiovascular risk was calculated and the action that it recommends I take. So it provides clinical decision support and makes it easy and actionable. New tech solutions that have come up since the pandemic, there's a whole bunch. We can now connect with our patients by phone, text, video, Bluetooth-enabled monitoring devices. We have some new home-built tech solutions, including a two-way texting platform and a tracking tool that integrates into our EHR. So with the team data and technology in place, we built the workflow for the pilot. Patients are referred to the virtual care team by their PCP. They are also sent to us by our population health team when they're doing their outreach to our uncontrolled hypertensive patients. We also did a text campaign to our current smokers, and those patients can self-refer for smoking cessation just by responding to that text. The majority of our patient visits are virtual. Inpatient visits happen when patients need labs or retinal screen or foot exam or device teaching. The visits are 30 minutes with the care coordinators. Nurse visits can be 15 or 30 minutes. The care coordinators do most of our diabetes education, whereas the nurse handles most of the hypertension and smoking visits. If medical decision-making occurs, then the medical provider joins at the end of the visit, and that makes the visit billable. The visits occur every 2 to 4 weeks for 3 to 6 months. So compared with usual care, we designed the virtual care team to provide enhanced patient communication and care coordination, more frequent appointments, longer appointments, standardized care, improved access to affordable medication, and to support the PCP and offload the burden of this protocol-based care and let them focus on other things. So outcomes. The pilot ran from April until December 2021. During that time, we enrolled 400. This was just 2 days a week, I should be clear. So Wednesdays and Thursdays, total of 16 hours per week. We enrolled 428 patients in that time with 111 graduates. There were 1,366 visits. Most of those were phone visits. By the final month of the pilot, the team was seeing 27 visits, total visits per day, 15 of which were seen by the provider, and 10 of those were billed at our full PPS rate. And then looking at our clinical outcomes, broken down by the 3 conditions. For hypertension, we are looking at the 30, 60, and 90-day buckets. So all of our patients who are enrolled in the virtual care team for hypertension and had a measurement done during that interval appear in those 30, 60, 90-day buckets. We're comparing them to, we looked for comparison groups just to find out if our program was having an impact. And the comparison group that we chose were patients who had the diagnosis of hypertension added to the problem list during the same measurement period. So you can see by looking at the buckets, it looked like the program had some effect. And then in the final box, we're looking at current control rates of our graduates. So we've had 150 patients enrolled, 38 graduates during the pilot. And among the graduates, the control rate was 82% versus 63% for our total population. So we want to continue to follow this over time to make sure that ever having been enrolled in this program has a continued benefit for patients. Likewise, for new onset diabetes, we had 185 patients enrolled. By the end of the pilot, 55 had graduated. We chose the comparison group that we chose. This was really apples and apples because the comparison group was just patients seen in our organization who had new onset during the measurement period, new onset diabetes, that were not referred to the program versus those patients who were referred and enrolled in the program. So we can tell at the outset that the patients who were enrolled in the program actually were sicker at the outset, but by 3 months were much more likely to have their A1C less than 8. So this is at less than 8, not the less than 9 rate, and continue to have good control at 6 months. The current control rate refers to A1C less than 8 for our 55 graduates. They're at 91% versus 63% for our total population. And comprehensive diabetes care measure, that is A1C less than 9, blood pressure controlled, retinopathy screen done, and urine microalbumin done. So among the virtual care team graduates, that has been completed in 78% of patients versus 25% in our total population. Oh, I should mention that this is really exciting for us and for the team. The team, on so many occasions, we had a new onset diabetic who received the education, took the medication, was seen by us frequently every 2 to 4 weeks, and it changed their life completely. And their diabetes, they lost weight, their diabetes completely remitted. So we've just seen a lot of cures with these new onset diabetics, and that's been really exciting and reinforcing for the team, and gives them a lot of sense of meaning in their work. For nicotine cessation, this is a hard nut to crack. Over the often quoted success rate, unassisted quit rate for the public in general is 7% when patients try to quit, when individuals try and quit smoking. We've had 90, as at the end of the pilot, we had 91 patients enrolled. Of those, 22% had quit, 30% had reduced, 18% were unchanged, and the remainder hadn't had a follow-up visit yet. So promising. It also seemed to have an impact on reducing our disparities. So again, this is looking at our organization-wide quality metrics for diabetes and hypertension broken down by race and ethnicity. The red and green refer to if that group had met our organizational goal. Our goal that we chose for ourselves for A1C less than 9 is 80%, and hypertension control also 80%. So you can see the virtual care team grads, are virtually universally have met our goal, and the disparities are reduced or eliminated among the graduates. Challenges, we have had challenges. Patient flow, just the mechanics of it we still need to work out because we have 1 nurse and 2 care coordinators funneling patients into 1 medical provider. So that would lead to some gaps and bottlenecks in the scheduling. Patient tracking, it's really important to us that we embrace the population that's been referred to us and we don't lose track of them, but that's time consuming. We've had to do lots of refinements of our patient tracking tool. Staffing is hard because our team is specially trained. So if there's outages, we can't get cross cover. And that was especially problematic during the Omicron surge when we had a lot of staff out. Coordinating care with the sites, we're still working on that. Patients who don't fit the protocol. So not everybody can be managed by a protocol. So we've discovered that our diabetes and hypertension population is really diverse, and we're learning how to meet the various needs of the individual patients that we serve. data validation is just really important, and the challenge was making time for it. But it is critical because we needed to believe the numbers to know if we were having an impact and to make the decision to spread the project. So what we've learned is that carving out time to focus on a single clinical condition helps. Standardized care produces more consistent outcomes. Frequent visits are necessary to overcome clinical inertia. Trained non-licensed providers like our care coordinators provide tremendously valuable service to our patients. The convenience of telehealth allows frequent touches, and remote patient monitoring provides better data and increases patient engagement. And these also allow centralization and scale of team-based care. Word about the funding. We had received grant money during the pandemic to support the expansion of telehealth, and we used that for some of our startup costs. And then our ongoing salary expense is being covered currently by our visit revenue. Oh, another word just about making the business case for this. The other benefits that we're hoping for is that this will improve our provider experience and hopefully improve our recruitment and retention, decrease attrition and turnover. And then we also are thinking that this is such a flexible model that this will make us more adaptable to kind of changing conditions in the healthcare environment. Next steps over the next 6 months, we plan to expand our services to 4 days per week. We're adding a clinical pharmacist. We're going to increase the referrals from our population health department and target specific populations for enrollment. We'd like to add more resources for nutritional counseling and obesity medicine. We have a couple of providers who are just finishing training in obesity medicine. We'd like to enhance our services for childhood obesity, fatty liver, and hyperlipidemia. And we're also using the team for onboarding and training of new clinicians because we don't want to silo all the knowledge of best practices for hypertension and diabetes in a single team. So we want to push that knowledge to the front lines by bringing the front lines in and rotating them through our team. And that's it. I've included the email address for our data analyst if you have any more specific questions about the data, and I'm happy to answer any questions.
Thank you so much, Melissa. I actually have a question to get us started. And a lot of the folks in the room too actually do have ECW. So it's kind of great to hear what your team has been able to do with the program, with the electronic health record. But as you know, we have a performance improvement project, and one of the key things that we are focusing in on is with data validation. It seems like it's the number one conversation topic throughout all of our meetings. But what did you do, especially in the beginning, to help support data validation and making sure that process and that information you're receiving is correct?
Yeah, so from the beginning, we have excellent in-house data analysts, but they don't necessarily have a medical background. So we'll try and describe our question to them, and then they'll build the query. And then they immediately give it back to the person who asked the question and just say, how does this look? And then it's an iterative process. And luckily for us, because it's in-house, the turnaround time is pretty quick. So Stephen will run a report, he'll send it to me, the team and I will look at it, and we'll just we'll look at individual patients and see if it makes sense. And it usually never does the first time. So it'll take, a back and forth of about, 4 or 5 iterations. And then, and then it'll work for a while and it'll break and we'll have to go back and fix it again. So yeah, it's always a moving target.
Thank you. And looks like Dawn has a question in the chat box too. Can you speak more to leadership engagement and the time it took to develop this pilot? That's the first part of the question. Then we'll go to part 2.
Yeah, leadership was very engaged. So it began with we had the idea. It was the outgrowth of a previous project that we had done prior to the pandemic that was looking specific. Actually, leadership came to us and they said, we want you to do something with diabetes. It came to the quality department. And so we looked at our department and said, well, why don't we, for the same reasons I mentioned earlier, I said, why don't we start with our new onset diabetics? Because they seem, like low hanging fruit. And we and we had great success with that prior to the pandemic, but we weren't able to spread it. We got stuck because at that time we didn't have all this virtual technology, and we couldn't reproduce the team and have one in every of our 17 sites. So it was siloed and stuck. So this was a great opportunity to say, oh my gosh, like, look, our quality scores tanked during the pandemic. Like, this is a burning platform. Now we have these new tools at our disposal. Also, part of our strategic plan is we're about a third of the way through our 3-year cycle. And one of the items on our strategic plan is to become a diabetes center of excellence. So all of this, the circumstances and our organizational goals were all aligned. The time it took, so I would say we started where we already had the foundation from prior to the pandemic. We had some of the clinical program and some of the expertise already in place for the new onset diabetics. So it was building onto that. So the planning was about 3 or 4 months. And then, so I think we started in late January, early February. We started seeing our first patients in April. We had to, do the training, build the team. And then I think I included the slide that just showed how our number of visits increased and kind of got to the current level at around September. So maybe 4 months in, we were kind of fully operational. But have been learning every day. We learn something new.
And Dawn has a couple more questions that she wanted to ask, but how is this project infused in your QI plan and the work of the QI committee? And have you shared this pilot result with your patients in your community?
It is pretty embedded, and it's kind of really gotten woven into our thinking about solutions now, because I would say for all of the clinical conditions that we're addressing, we think about this model now as a potential solution. So, when we think about our other chronic diseases and even some of our like infectious diseases, like our STI treatment and our Hep C treatment, HIV prevention, like how can we use a centralized team like this to address those issues? So this is kind of a new tool in the toolbox that we're hoping we can apply to a lot of our clinical quandaries. We haven't shared it. That we've done a couple of like external presentations with other healthcare organizations, but we haven't made this known to the community yet. I think it's still pilot stage, and the numbers are small. The goal is to grow it over the next 6 months and really just see an impact, not just start to see the numbers be large enough that it'll have an impact on our whole, population quality metric. And at that point, I imagine maybe for our next annual report, we'll be including something about this.
Great. Yeah, thank you so much. Any additional questions? So thank you all so much for being able to spend a little bit of time after the 11 o'clock hour to attend the training. And you're going to be receiving a survey on this training and evaluation, and we would really appreciate if we can complete the survey and provide us feedback, because we want to continuously provide high quality trainings to you and your healthcare teams. If you have any further questions, you can contact me at rnaik@nvpca.org. And with that shared, on behalf of Nevada Primary Care Association and the American Heart Association, thank you so much for joining us today.